Greetings to all. Today we shall discuss a few questions regarding flare in lupus nephritis. So, how do you define a renal flare? A renal flare denotes recurrence or worsening of disease activity after a period of quiescence or response, as per the ACR-EULAR endorsed criteria. What are the types of flare? You could have a proteinuric flare or a nephritic flare. Proteinuric flare, otherwise known as nephrotic flare. So, how to define a proteinuric flare? More than twofold increase in urine PCR from low baseline, or an absolute increase to more than 1 gram if baseline UPCR of less than 0.2. No active urinary sediment or rising creatinine. A nephritic flare, on the other hand, is defined as more than a 30% increase in serum creatinine from baseline, and or a urinary sediment that's active, that is having either dysmorphic RPCs or RBC casts, reflects a proliferative activity and not a pure podocytopathy. So the take-home message here is nephritic flare usually implies active class 3 or 4, which requires a prompt reinduction. A nephrotic or a proteinuric flare may reflect membranous nephropathy transformation, either class 5 or a podocytopathy. So one has to consider biopsy before escalating. When is a repeat renal biopsy indicated in suspected lupus nephritis flare? And why does the KDIGO 2024 emphasize this? The KDIGO 2024 practice points repeat biopsy when, number 1, there is a diagnostic uncertainty. Number 2, when there is unexplained deterioration. Number 3, there are high stakes in treatment decision. Diagnostic uncertainty means whether the flare reflects active proliferative disease, chronic damage, scarring, or a class transition from proliferative to membranous. Unexplained deterioration means worsening renal function without a clear cause. So we have to rule out a TMA or a carcinogenic transformation or a superimposed drug toxicity or interstitial nephritis. High stakes treatment decision means escalation carries significant toxicity. So we have to confirm ongoing activity versus irreversible chronicity before another course of immunosuppression like cyclophosphamide or high dose of steroids or a CNI. So the bottom line here is lupus nephritis can change histological class up to 30 to 40% of times. And activity chronicity indices guide whether aggressive immunosuppression is likely to help have a high activity or be futile by high chronicity with glomerulosclerosis versus tubular atrophy. Please remember that biopsy in a lupus nephritis gives static information about a very dynamic process that is ongoing. What is the evidence for belimumab in lupus nephritis flare prevention, and how does KDIGO 2024 use it? The BLISS-LN trial, author is Fury et al., NEJM 2020. Belimumab added to standard of care. Standard of care here meaning mycophenolate or cyclophosphamide or azathioprine, improved renal response and reduced renal-related events, including flares, over a period of 104 weeks. So the trial duration of the BLISS-LN trial was 104 weeks. Post-analysis shows decreased flares, fewer LN flares with belimumab versus the standard of care, and reduced eGFR decline, slower kidney function decline with belimumab. The KDIGO 2024 suggests that belimumab or voclosporin may be considered as an add-on initial therapy with class 4 or 5 or plus or minus 5 lupus nephritis, shifting the paradigm from escalate at flare to triple therapy upfront in high-risk patients. So the bottom line here is consider a triple drug regime with belimumab in patients at high risk of LN flare or with advanced CKD which is likely to progress fast. Class 4 lupus nephritis in remission on MMF and HCQ develops a nephritic flare at 18 months. What do you do? So, as per the recent guidelines, reinduce the original regime. If it is previously achieved remission and was tapered inappropriately or non-adherence is suspected, reasonable first step for a mild to moderate flare. Number 2, if there is a switch induction class, for example, MMF can be changed over to cyclophosphamide, or vice versa if flare occurs on adequate dose therapy per the Eurolupus ALMS precedent of broad equivalence. Number 3, add a CNI, voclosporin. The Aurora shows a higher complete renal response, stable EGFR at 3 years, best for patients with heavy proteinuria with EGFR more than 45 ml per minute per 1.73 meters squared. And please remember that voclosporin here has only a podocyte stabilizing effect. Add belimumab, that is a fourth option, if not already in use, particularly when the goal is durable flare prevention rather than acute response alone. So to summarize, what would be the flare prevention checklist? First, you check adherence to all drugs. Proteinuria target, by 12 months urine PCR should be 0.5 to 0.8 gram per gram. Steroid taper should be 3 to 6 months, less than 7.5 milligram per day, gradual, not abrupt. Maintenance duration more than 3 years post remission. Avoid early withdrawal of MMF as a plus or minus belimumab or voclosporin. And in high risk patients, consider triple therapy with belimumab or voclosporin upfront. Most of the answers I have given from the KDIGO 2024 guidelines and the belimumab and the voclosporin trials. Thank you. What is the evidence for voclosporin in lupus nephritis? Aurora 1 trial 2021. It is an RCT. Voclosporin with mycophenolate with low-dose steroid versus MMF plus steroid 52 weeks. Significantly higher complete renal response rate with voclosporin add-on. This is further supported by the Aurora 2 trial published in 2023. Long-term extension for 3 years, sustained renal response and stable EGFR, acceptable long-term safety of voclosporin. So the key distinction from the initial induction now favors triple therapy upfront in high-risk patients. A flare on established therapy typically prompts addition of a mechanistically distinct second agent rather than dose escalating the current drug, which gives diminishing returns and cumulative toxicity, especially cyclophosphamide. What predictors of flare should be tracked in maintenance therapy, and how should HCQ steroid tapering be approached? There are predictors and markers. One is serological, rising anti-dsDNA, falling C3C4. They are adjunctive, they are not standalone, they can be taken as triggers. Persistent proteinuria, failure to reach a UPCR of 0.5 to 0.8 gram by 12 months predicts flare and worse renal survival. HCQ non-adherence is the strongest modifiable risk factor. Alternatives are less effective, more flares. Investigational, there are some markers that are being investigated, that urinary MCP1, TBEAK, and CB SCAPS, promising but not yet standard of care. If you take the tapering strategy, glucocorticoids taper gradually, target less than 7.5 milligram per day prednisolone, equivalent by 3 to 6 months. Rapid withdrawal is a recognized flare trigger. And regarding maintenance therapy, continue the MMF or AZA plus or minus belimumab or voclosporin for a minimum of 3 years post-remission. Earlier withdrawal is linked to higher relapse.